The use of ultrasound by trauma and critical care surgeons originated from the focused assessment with sonography in trauma, or FAST examination. It soon became apparent that the same techniques of the FAST exam were applicable in the critical care setting as well. This has resulted in an increase of surgeon-performed ultrasound in the intensive care unit as well as in the emergency department. Perhaps the most important advantage of ultrasound in the acute setting is portability. Ultrasound machines travel to the patient and not the patient to the machine. This avoids the risk of transporting patients to the radiology suite. In addition, the ultrasound probe can be maneuvered to visualize multiple planes and angles without moving the patient in the bed. A useful consequence of the portability of ultrasound is that it facilitates repeated examinations. Critically ill patients frequently require reassessment. A second advantage of ultrasound in the critical care setting is that it can be used as both a diagnostic and therapeutic tool. For example, with bedside ultrasound, you can determine that a patient has ascites. Unlike other technologies, you can also use it to tap the ascites. In this section, two common applications of ultrasound in the acute setting will be described. These are ultrasound-guided thoracentesis and ultrasound-guided central line placement. First, let's look at ultrasound-guided thoracentesis. The presence of pleural fluid can be difficult to discern on plain chest radiograph. This is particularly true of the supine portable chest X-rays obtained on ICU patients. Pleural fluid tends to layer out posteriorly, creating a general haziness. Overlying lung pathology can easily obscure a pleural effusion. Does this patient have a pleural effusion? The CT scan reveals that the answer is yes. However, transporting the patient to the scanner requires a considerable expenditure of time and resources. An easier and less expensive way to answer the question is to use bedside ultrasound. As a bonus, the ultrasound technique can also be used to tap the fluid if necessary. Ultrasound examination of the pleural space is performed with a patient in the supine position. Putting the bed in reverse Trendelenburg is useful, but not essential. A 3.5 MHz transducer is placed in the mid-axillary line at the level of the 9th or 10th rib. This will help to visualize the hepatorenal or splenorenal fossa. The transducer is then moved cephalad to reveal the diaphragm and pleural space. It may be necessary to slide the transducer up one rib space. Since ultrasound does not transmit well through air-filled structures, the lung appears as an indistinct gray shadow. Contrastingly, when pleural fluid is present, it's readily identifiable as an anechoic black shadow just above the diaphragm. This is easier to detect in a dynamic ultrasound image. The diaphragm is readily seen as a bright echoic white line that moves in time with the patient's breathing. In order to perform a thoracentesis, first localize the fluid and place a mark on the patient's skin to indicate where to insert the needle. Next, prep and drape the area. Put on a sterile gown and gloves. Anesthetize the skin, insert an 18-gauge needle at your mark, and aspirate the fluid. For a large effusion, a central line kit may be used to drain it. Finally, confirm complete drainage of the fluid with ultrasound imaging. Pleural effusions may also be drained under direct vision using real-time imaging. This is not usually necessary unless the fluid is loculated. The procedure for this scenario is the same, except the ultrasound transducer must be placed in a sterile sleeve. In addition, you'll need to use a sterile gel such as KY jelly. Let's move on to ultrasound-guided central line placement. Traditionally, central lines have been placed using a landmark-based technique. Unfortunately, this technique can result in numerous complications. These results include iatrogenic pneumothorax and inadvertent arterial cannulation. The use of ultrasound to guide central line placement has been shown to result in shorter procedure times, fewer cannulation attempts, and fewer unsuccessful line placements. Not surprisingly, ultrasound guidance is also associated with fewer complications. The placement of central lines in the acute care setting can be particularly challenging, since many critically ill patients have anasarca. This renders a landmark-based approach even more difficult and dangerous. In addition, many intensivists have experienced the frustration of multiple cannulation attempts only to discover belatedly that the vein in question was thrombosed due to multiple previous lines. Since ultrasound guidance provides a means of central line placement that is both faster and safer than the landmark approach, there's really no reason not to use ultrasound in all central line placement attempts. Ultrasound guidance may be used in the placement of central lines in the internal jugular or subclavian veins. Since the internal jugular approach is far simpler, we'll focus on that approach. Proper positioning of the patient, the operator, and the ultrasound machine are key elements of the procedure. The patient should be placed in Trendelenburg with the neck slightly rotated to the contralateral side. Avoid rotating the neck too far. This will distort the vascular anatomy. For an internal jugular cannulation, the operator and ultrasound machine should be on the same side of the bed. The operator should be at the level of the patient's waist, and the ultrasound machine should be at the patient's head. This will place the operator, the vessel, and the machine in a direct line. The next step is to identify the internal jugular vein and clearly distinguish it from the nearby carotid artery. This should use a 7 MHz linear transducer in a transverse orientation. Compressibility and respiratory variation are two ultrasonographic characteristics that are specific to veins. A slight increase in downward pressure of the transducer should result in compression of the vein, but not the artery. Additionally, the internal jugular vein should show diameter changes with respiration, while the carotid artery should not. Non-visualization of the vein should raise suspicion of thrombosis. This can be investigated further by interrogating the neck, both cephalad and caudad. There are two different approaches to ultrasound-guided vein cannulation, static and dynamic. The static approach involves identifying the internal jugular vein with ultrasound and marking a cannulation site on the skin. The neck is then prepped and draped, and the operator dons sterile gown and gloves to place the central line. In the dynamic approach, real-time ultrasound is used throughout the cannulation to directly visualize the catheter insertion. Both techniques are superior to the landmark-based technique. Ultrasound guidance can also be used for subclavian central line placement, although the subclavian vein is more difficult to visualize. This is due to its position beneath the clavicle. Additionally, since pressure cannot be directly applied to the subclavian vein, the compressibility test can't help to distinguish the vein from the artery. Because of these difficulties, the detailed description of ultrasound-guided subclavian cannulation is the subject of an advanced ultrasound course. It should be noted that in obese patients or patients with anasarca, it's easier to visualize the subclavian vessels through a longitudinal supraclavicular approach. In thin patients, a subclavicular transverse approach is preferred. Surgeon-performed ultrasound has numerous applications in the diagnosis and treatment of patients in the acute care setting. In this brief segment, we've described two of the more common uses: ultrasound-guided thoracentesis and ultrasound-guided central line placement.